Okay, great. Well, thank you, Terry, for inviting us to provide this information for your elder care group. As Terry mentioned, my name is Denise Wells. I'm the Executive Director of the Nursing Home Ombudsman Agency of the Bluegrass, and we are advocates for residents who live in long-term care settings. A quick and dirty version of what the Ombudsman program is. We are a resident advocate for residents in long-term care, and in Kentucky, that includes nursing homes, personal care homes, assisted living communities, and family care homes. And that assisted living community bullet point was just added in July of last year. So there have been a lot of changes going on with that in that setting, care setting. And so I'll go over some of those here shortly. But the Ombudsman program is authorized through the Older Americans Act, and that gives us the authorization to investigate and resolve complaints, provide information to residents, families, and staff about things like residents' rights, Medicare and Medicaid, other issues in long-term care. And it also authorizes us to advocate for systemic changes to improve resident care and quality of life. So some of our responsibilities, we have to make sure that residents have regular access to the Ombudsman program. So in the Bluegrass District, we write grants, and we're a nonprofit, so we're able to receive tax-deductible donations to have ombudsmen in our 17 county region that go and regularly visit about once a week the nursing homes and other care settings that they have in that county. And then, of course, we identify and resolve complaints made by or on behalf of residents, provide information and technical support, and then do some advocacy in the legislature, both on the local, state, and federal levels. Ombudsmen in the long-term care setting are 100% resident focused. We have to have resident consent before we really do an investigation or share any information, and the resident guides our actions. So we may have the same exact complaint in two different facilities, like the food isn't very good, but what we do in those two facilities will be guided by the resident who brought the complaint to us. And so in that same vein, we try to resolve the complaint to that resident's satisfaction. And I'll talk a little bit more about that as well. But we try to really empower residents to be able to self-advocate for these things. So when somebody brings us a complaint, we might inform them of how they could address it. And if they'd like our help, then we go forward with assisting them. Some of the things we don't do, we are not licensing, we're not regulatory, we are not able to cite a facility or fine a facility. We do know a lot about the federal and state regulations, and we're able to refer back to those when we advocate for residents, but we are not held to the regulatory requirements in terms of what we advocate for. We can advocate for anything regardless of what the regulations say. We do help residents file complaints with the regulatory body if necessary. We also don't provide direct care. We are really kind of there to make sure that the people who are responsible for providing direct care do those, provide that care. And we are not adult protective services investigators. So while we do investigate complaints about abuse, neglect, or exploitation, we are not held to that legal threshold of abuse, neglect, or exploitation. And we are not really the finder of true facts or the body that puts somebody on an abuse registry. We work to report those complaints on behalf of residents. But if Adult Protective Services comes back and says we couldn't find anything, we could not substantiate that complaint of abuse, neglect, or exploitation, then we can continue to work towards making sure a resident is comfortable in their home with the caregivers they have. What do we investigate? We investigate all kinds of complaints. We can do individual complaints, group complaints. If we walk into a building and we see something's wrong, we can initiate a complaint, like if it smells like the trash hasn't been taken out, or if the hallways are cluttered with Hoyer lifts and empty wheelchairs and residents aren't able to get around, we can address those on ourselves. And then it's really important that the Ombudsman program does not share any information without resident consent. And so residents can request that they file a complaint and they remain anonymous, or they can say, I don't want you to work on this, but here I'm going to tell you about it. And so we can continue to work to gather some facts, but we would not file a complaint or address that issue with staff unless the resident gave us consent, or to use their name. We would not use their name unless we had consent. And like I said, we really call upon others to fulfill their responsibilities to residents, whether that's the facility staff, the Medicaid office, the Office of Inspector General, the regulatory body, anybody that the resident is relying on to provide care. Some of the types of complaints we have, like I said, we really handle a wide variety of complaints, and it's not limited to regulatory issues. And so one of the most important things that I like to tell people is, there's really nobody else in Kentucky that you can call with a complaint that is not a specific regulatory violation. So for example, we had a facility in Lexington change their cable provider a few years ago. And when they did, they dropped the SEC network from their package. And so that's not really something you can call the Office of Inspector General about, but you can call the Ombudsman. And because the Ombudsman can advocate for anything that benefits your quality of life or quality of care, we worked with the residents to write a letter to the new management to make sure that they understood how important that was to the social health of the facility, of the residents. Because when you live in a nursing home and you have complex medical needs and you share a room with somebody who has complex medical needs, and you go and you have to eat in a communal dining room, or you eat in your room and you don't have very many visitors, it is essential that every opportunity you have to stay in contact with your community is upheld and honored. And so even though it was a TV channel, that was really important to the Ombudsman program because it was really important to the residents. And there's really nobody else that you can call with the complaint like that. And then just as a final note about our complaints, we have to have resident permission. So even if you were to call and say, my mom, my sister, my neighbor is in the nursing home and they are having problems with their medication or their showers or the food, the first thing we do is go and visit the resident and kind of piece out whether that resident shares that concern. And if they do, then we go ahead and we work with the resident to address it to their satisfaction. And if they don't, then we are not able to move forward. We could go and see if other residents have that concern and address it through that means. But sometimes we'll get calls from families who say they're not getting my mom up and dressed, and she used to love wearing all these matchy outfits and now she's just wearing sweatpants and a t-shirt and she's not even putting on a bra. And we go and we visit with mom, and mom says, oh my gosh, if you try to put me in a bra, I will revolt. I will not talk to my daughter ever again. Don't you ever put me in a bra again. Those are the most uncomfortable things to wear. Well, we're not going to go and tell the staff you need to put a bra on mom, because that's not what mom wants. So we take our direction from the resident. And
Hey,
I will
Denise,
tell you that, yes.
I'm sorry, we never really got a chance to talk about this because we had that little issue in the beginning, but there's a question about complaints.
Yes.
If in the question box, do you keep aggregate statistics by facility on complaints? Sort of like the BBB, the Better Business
Yes.
Bureau.
We don't have that information kind of publicly available, but we do. All of our complaints get documented in a specific software system that we can pull reports with. However, when somebody is looking for aggregate information about the care in a long-term care facility, we send them to the Medicare Nursing Home Compare tool. And if they're looking at personal care homes, which I'll talk a little bit about, OIG, the Office of Inspector General, does have some information about that available. But really the best way to try to suss out the kind of care or the environment that a facility has is to go and visit and kind of walk around, listen to the staff, listen to the residents, look to see if everybody's clean, if the activity calendar lists things that are appropriate, visiting during meal times to see what are they serving, what are the portions like, are the residents being helped to eat, things like that.
We have one more question,
Yeah.
while we're in the complaint part. Um, I assume a person with POA can report an issue and it be addressed regardless of the resident, i.e. dementia patient.
So yes and no. It really depends on the individual situation. A power of attorney can certainly call the office and we can go and investigate. But again, the first thing we do, even if it's somebody with dementia, even if it's somebody who can't communicate to us, the first thing we do is go and visit with the resident and try to communicate with them about the complaint that's been reported to us. And if the resident is completely unable to communicate, then we would go ahead and move forward with the complaint as reported by the power of attorney. And we would use that power of attorney as our primary contact to try to work on that. However, even a resident with dementia, even a resident with a guardian, a legally appointed guardian, still can give us direction as to what they want or what they don't want. And so, for example, it really depends on the situation, but we had a guardian, and a guardian is court appointed. Somebody took this resident to court, the daughter went to court, talked to a judge, and a judge said, this person is incompetent to make their own decisions. And so we are appointing you, this person's daughter, to make those decisions for her. And so in the paperwork about guardianship, in the regulations about guardianship, you are still required to discuss with the person what their preferences or wishes are, but you can a lot of the decisions have to be made by that guardian. But this woman wanted her mom's blinds to be shut during the day, and the resident wanted them to be open. So in that situation, we advocated for the resident because that's a decision that they still had the capacity to make, and there was no negative health outcome or consequence to that. So it really depends on the complaint and on the resident's ability to continue to communicate. Any other questions before I move to our next section? Okay. Oh, please don't tell me I've frozen. Oh, no. Okay. So the types of licensed long-term care settings in Kentucky, I kind of went over these, but we'll go over them in more detail in these next slides. But before I do, a lot of the information that I'm sharing with you can be found in our publication, From Admission to Care, Everything You Need to Know About Residential Long-Term Care in Kentucky. And this is on our website. You don't have to give us your email address to get it. You don't have to pay for it. It's everything that the program does is free, regardless of income or whether you live in a long-term care facility right now. Anything that we have on our website is free. And so this book goes over some of these things that I'm talking about. It needs to be updated because of these regulatory changes, and I expect that we will have a new one ready to publish in January when these new regulations go into effect. But this is just a resource for you to go and look at this after we get done today. And I didn't get the PowerPoint to Terry before now, but I'll get that to you and you can share this with everybody as well. Okay, so you decide mom needs to move into an assisted living, or dad's in the hospital and he needs to go get rehab at a nursing home. And so the hospital tells you, what nursing homes do you want us to send referrals to? And so you hop onto Google and you look for nursing homes in Lexington. Well, that is incredibly misleading because out of all of these little red dots that pop up when you Google that, only a few are nursing homes, and only a few would be appropriate for somebody who needs nursing home care. And if you searched for assisted living, you're going to end up with home health agencies popping up because they're placing ads, and they know that when somebody's searching for this, that's when they might need our services. So instead of Google, call the Ombudsman program, call the Bluegrass Area Development District. They've got a resource for people with disabilities, and they can get you connected with us, or they can get you a list. We can get you a list of places that would be appropriate. So we'll go through the different levels of care, starting with skilled nursing, the highest level of licensed long-term care in Kentucky. And so obviously that's a medical model, and all nursing homes provide assistance with activities of daily living. But the skilled piece, that first word is really important in this, that is intensive therapy. And so this is where somebody goes after surgery or after a fall or after a major illness that caused them to spend 3 nights as an admission in a hospital that kicks off their Medicare benefit. And so where you live, for the most part, most of these facilities are shared rooms, but some private rooms are available. A lot of nursing homes are now building their Medicare subacute rehab wings to be private rooms for everybody. But everybody also shares a congregate living space, dining space, things like that. And so you would be receiving housekeeping services, dining services, grooming, activities, like I said, bingo or movie night, things like that. And then social services. Every facility is required to have somebody working in social services for discharge planning or to help, with Medicaid or Medicare questions, things like that. And then health services, currently, these facilities are required to have an RN on staff 8 hours per day, and then state registered nurse aides must be available 24 hours per day. And then the therapy services are basically as ordered by the doctor from the hospital, for the physical occupational swallowing therapy. They're inspected every 9 to 15 months by the Office of Inspector General. And primarily when you're in a skilled nursing facility, you're using Medicare. Some of you that might have a secondary insurance could pay some of the copays associated with that kind of stay. Medicaid does have some intensive rehab services for people who are on community Medicaid, but long-term care Medicaid does not pay for skilled nursing. You may have a long-term care insurance plan that covers some of this, and then the VA contracts with certain facilities to provide rehab. And in this level of care, your care plan is the most important thing to make sure that you're getting what you need while you're there, or your loved one is getting what they need while they're there. And although some hospitals have their own subacute or rehab facility wings or things like that, it's still a skilled nursing facility. It's not following hospital rules. And then nursing facilities. So once you drop that word skilled, once you don't need skilled care anymore, then you're looking at long-term care, custodial care. And that's also a medical model and provides assistance with those ADLs, activities of daily living, but there's not intensive rehab or therapy services. Very similar to the skilled facility, most rooms are shared. It's very unusual for somebody to have a private room in that intermediate or custodial care unless they are paying privately. Same personal services, for the most part, same health services. You can receive some therapy while you're in the nursing home under custodial care, but then you're basically going to be going back to getting skilled nursing services because Medicare will theoretically pay for some of those services. Same inspection schedule. 70% of residents in this long-term care setting are using Medicaid because private pay in this level of care runs about $10,000 a month because they can kind of charge for each individual incontinence brief this person uses, or each individual chuck pad that goes under them in the bed. So it can really add up quickly. And so it runs down assets or savings pretty quickly. There are some long-term care insurance plans that will cover this. Again, the VA has some contracts to cover this. And again, the care plan is the most important piece of anything that really directs what happens in the day-to-day for a resident in a nursing facility. Personal care homes right now, this is one of the things that's going to change, but right now, personal care home is a medical model, and they are providing supervision and some assistance with activities of daily living. These are primarily private apartment style units. There is not likely to be a full kitchen, but you may have a kitchenette with a microwave and a mini refrigerator, and you've got your own bathroom. And then there are still congregate living spaces. Personal services are primarily that housekeeping, dining activities. Social services are not as robust in a personal care home. And then health services, the personal care home regulation right now requires non-professional resident assistance. So you don't have to be a registered nurse aide to provide care. And currently, the regulation basically just says you have to have one awake staff member per floor at all times. And what's unique in personal care homes, and will continue, is that residents have to be ambulatory. You have to be able to walk, or you have to be mobile, non-ambulatory. So you have to be able to move yourself in a wheelchair. And then home health can be used in personal care homes for people who require more assistance, but that's primarily on a short-term schedule. And then these levels of care currently are inspected annually by the Office of Inspector General. This is all private pay or long-term care insurance. You can use VA aid and attendance in some personal care homes. And then you can have Medicaid and live in a personal care home, but Medicaid is not paying for that personal care home level of care. Like I said, it is all private funds or long-term care insurance.
Hey, Denise,
Yes.
is memory care under personal care? Does that kind of fall under that category?
So memory care is really just a marketing term. That's going to change, but currently memory care is just a marketing term. So personal care homes like Cedarhurst in Beaumont, they have their 3-story apartment area, and then they've got one secured dementia care unit, and it is licensed the exact same way. And actually, it's not even a separate license, it's all the same license, but they've secured it, and they've got some more dementia friendly activities and things like that planned, but it's not an actual level of care currently. That will change, and I'll go over that when I get to the new assisted living regulations. But right now, if you Google memory care, that's not a real level of care in Kentucky. Okay. So this slide, specialized personal care homes, this is there are not very many of these in the area, and they're not really for aging. They are primarily low income care homes for people with severe mental illness. And so it is a medical model. They are able to provide, medication distribution and things like that. But it is very low income. For the most part, it is paid for through private funds for people who have family that might be assisting in their finances. But most residents are utilizing a state supplemental income option and paying their disability. So most of these facilities are running about $1,200 a month. And so they are very low income. In the Lexington area, we've got Rose Terrace in Nicholasville, Waynesburg Manor all the way down in Waynesburg, and then we've got 2 in Cynthiana that provide care for people with severe mental illness. This is not really, like I said, this is not really an aging home. Most of those places have stairs or things that are not really conducive for somebody who's got mobility issues. But it's primarily very similar in care needs as these other personal care homes that I've already reviewed. So, and these are not going to change. When I go over some of the changes, personal care homes will change, but these specialized personal care homes have their own regulations, and they will not be changing. And then finally, well, not finally, family care homes right now are kind of dying. There's not very many of them anymore, but it's basically somebody in a private home that has a license to take care of up to 3 people who are not related to them. But primarily it's supervision. A lot of the residents in these family care homes have developmental or intellectual disabilities. And so, they've lived there for a long time. They go to adult day, they go to the senior center for activities, and then the person who runs the family care home is basically just supervising, providing meals and housekeeping and things, and medication distribution or administration, I'm sorry. Similar to the personal care homes that use SSI, most residents in these care homes are utilizing a state supplement to pay for that care. And again, so it's very similar to the personal care homes, the SMI personal care homes, where it's about $1,200 a month. And then current regulations for the assisted living communities. So that's places like Highbridge, or not Highbridge, High Grove at Tates Creek, Meadowthorpe, Pleasant Meadows, places like that. Current regulations, assisted livings are just social. They are not supposed to be providing care. They can do medication reminders, but they can't hand you your pills. They can't, get a pill out of a bottle. And so again, these are primarily private apartments with congregate living spaces or dining spaces. They may provide housekeeping, dining services, activities, but you're really looking at a lease agreement or your contract to see what services are available. There's not really any services that have to be provided currently. However, most facilities have some non-professional resident assistants to do that medication reminders and things like that. And again, residents have to be able to walk or able to move themselves in a wheelchair. Currently, if you live in an assisted living community and you need more care, most residents are utilizing home health services, and it may even be owned by the same company that owns the assisted living community, but it's an outside provider. It's not the employees of the assisted living community. And currently, these facilities are inspected annually by the Department of Aging. So they're really just certified, but now they will be licensed, and I'll go over those changes. This is all private funds. I don't think that any long-term care insurance would really pay for assisted living in Kentucky because there wasn't any medical care provided. Okay, so now new long-term care facilities, we're saying bye to the personal care home license, and all of those facilities are going to become assisted living communities, either basic health models or dementia basic health model. And I'll go over those levels of care in just a minute. But once these facilities have their next annual survey, if they have been in good standing, they will become assisted living facilities. Now, assisted living communities are going to move from being strictly a social model to having the choice to become a basic health or dementia care basic health model. They can continue to be a social model and not really change much of anything about their services, but they do have the opportunity to apply to become a basic health model. And so just a very broad overview, I'll go over this in a little bit more detail, but assisted living community license will primarily be, facilities can choose to continue to be that social model. And so they can provide assisted living services, but they can't provide that basic health service. They can't do the medication administration. They can still do the medication reminders. But if an assisted living wants to upgrade their services to provide basic health, then they would have to provide those assisted living services and basic health services. And those are defined in statute, but I'll go over some of them in a few minutes. And this is a level of care that does not have any secured dementia care. And then finally, the third option is the highest level of care within assisted living, and that is a dementia care license. And that's basically saying we provide basic health care in a secured dementia care unit. And as a condition of that, there's specialized training that's required. There's special life safety code requirements but it's primarily a basic health plus dementia care. And so the social model is basically going to stay the same, except they will be required to provide transportation or arrange for transportation for residents and provide at least one non-basic health related assisted living service. And so those are defined basically like assistance with dressing, assistance with grooming, meal service, medication reminders, things like that. Health services, these are going to remain non-professional resident assistants. All levels of care require that residents be ambulatory, be able to walk, or be able to move themselves in a wheelchair. And all levels of care will be able to continue using home health if desired, and if the facility allows that. That'll be a facility decision. One big change, though, is that the inspections are going from every year to every 2 years. And that was something that we really tried to fight against, because 2 years is a long time when you could have a change in ownership or, a big change in management. And that really leaves a lot of time in between inspections. Now, somebody could call and file a complaint, and OIG would go in and do a complaint investigation at any time, but we were really disappointed by this change in inspection schedule. Again, this social model and all the other models, well, the social model will remain private funds. One of the new things, though, is every resident in an assisted living community will have to receive a functional needs assessment, which will basically just be a nurse reviewing your medical needs and whether or not you are appropriate to live in that level of care. So somebody with moderate to severe dementia who can't manage their own medications, who can't self-administer medications, would not really be appropriate for a social model unless they had home health or intensive family supports providing that level of care. The basic health model is basically just adding on to the social model that they have to provide assistance with basic health needs. And so they they would be required to provide assistance with medication administration. And so because of that, there is now a requirement that they employ certified medication aides to assist in that administration, which is that was a whole big thing with the regulation changes that we really fought to make sure was included. And another really big, really huge change is that these assisted livings must have a nurse available either by phone, in person, or some other live two-way communication to basically supervise or delegate any sort of health service required. Again, residents have to be able to walk or move themselves in a wheelchair. And again, home health can still be used if the facility allows. 2 years, private funds. However, I think that this change will align Kentucky a little bit better for those long-term care insurance policies. We said that personal care homes could accept long-term care insurance, but most people who have used that insurance in personal care have had to really educate the insurance company that personal care in Kentucky is kind of like assisted living in other states. And so now that we're revising our regulations to be more in line with what is common across other states, we'll likely see long-term care insurance providers in assisted living basic health models. Again, the lease and functional needs assessment will be really important to people moving into these communities. And then the dementia care model is basically building off of that basic health model. So there's dementia care requirements, which are primarily that the staff have dementia specific training and that they have dementia specific activities and things like that. But one of the other big changes, the other big requirements in this step up level of care is that the unit has to be secured. So it has to have a lock. You have to put a code in, or somebody has to buzz you in to get into the unit itself. And then the apartment doors should not lock from the inside, which we also have a real problem with, but that has been the way it has been for a long, long time. you can lock the door from the outside. So like a CNA could lock the door from the outside, but a resident could not lock themselves in their room, which I understand could be a concern, but most staff are carrying a master key that can get them into any apartment anyway. So it wouldn't make sense that a resident couldn't choose to lock their door. But I digress. So this is the same every 2 years. Private funds probably going to be able to utilize long-term care insurance. And then again, the lease and functional needs assessment will really be important for residents living in this level of care. So before I move on to another change in licensed long-term care, does anybody have any questions about the different levels of care, about the changes that are coming to assisted living and personal care, or anything else that I've mentioned throughout these slides?
Oh, when do the changes go into effect? Good
Yes.
question.
So these assisted living regulations are final. However, we expect that they will kind of go into effect January, but then personal care homes are going to have, because personal care homes don't currently have a requirement to have a nurse available, they're going to have kind of like a ramp up period to be able to get that, to be able to get the certified medication aid. So we expect that in about 6 months after January, so July or so, that facilities will be held to this standard. And then for assisted living communities like High Grove at Tates Creek, they don't technically really have to do anything if they are going to stay a social model, except implement the functional needs assessment. Um, and so they may not make any changes. However, we have already heard from a lot of assisted living communities that intend to apply for a basic health model. And so that would basically be, they have to get the staff onboarded, they have to get the training done, and then they have to apply for that license. And OIG will come in and check to see that they've met those requirements.
You know when that will all be taking place?
That will just be, whether a facility changes their level of care will be all up to that facility. I think most places that are going to change to basic health have already made that decision, and some of them have already implemented increases in their fees to reflect that change.
Mm.
But we've also seen a lot of assisted livings have decided to close. Like Sarah Christian Village had a dementia unit in their assisted living, but they didn't want to adjust to follow these regulations, so they closed that unit and have made it, just standard assisted living. So we're seeing a lot of changes right now. A lot of places are changing right now, but the personal care home transition to assisted living will basically be when their annual survey comes up. So it'll be, all these changes will kind of be going into effect for the next 18 months, really.
Okay. And will there be a list somewhere of what all of the facilities have gone to or changed or not changed to?
Yes. So OIG will maintain a list like that, and then in the Bluegrass, we normally maintain our own list. So I expect that will be changing a lot though throughout the next 18 months. So for a list, you could always call our office or check the OIG website, and that's where they typically keep their list.
Okay. And then Aaron had a question. To qualify for nursing home care, I understand that the person has to need assistance with at least 2 of the ADLs. Can you go over those?
So yes, ADLs, I mean, are a very wide list of, a very long list of basically the things that you do in your home every day to make your house run, to keep yourself healthy. So they include things like eating, whether it's I need help because I can't cook anymore, or whether it's I need help because I can't bring a fork to my mouth anymore. So it runs that whole gamut. Dressing, and that may be, again, it can run the gamut of I just can't get the buttons of my shirt buttoned, to I need somebody to feed my arm through a sleeve or my legs through my pant legs. There's also grooming, almost all residents in long-term care or in nursing homes need help showering or bathing, brushing teeth, washing your hands. Toileting is a huge one, and that could be somebody with total incontinence where they're wearing incontinence briefs, or it could be somebody who just pushes a call bell because they need help to get out of their bed to be able to make it onto the bedside commode or walk to the toilet, and then assistance getting off the toilet, cleaning up, things like that. Medication, self-administration in nursing homes is allowed. So if somebody has an inhaler that they self-administer, that is allowed. It just needs to be documented that a doctor has made an assessment and has said that you're capable of self-administering that medication. But for the most part, medications are passed by a nurse or a Kentucky medication aid, certified medication aid. There is also, let me think. Activities, just transportation, things like that. Cleaning, personal cleaning, housekeeping, maintenance of your living space, things like that. It really, I mean, it's a long list. And so it's not to say that it's easy to find 2 ADLs that somebody needs assistance with, but somebody who needs a nursing home only needing 2 is fairly appropriate, or fairly not easy to meet, but just for people who need it, it's not inaccessible. It's accessible to most people who need nursing home care. I also see a question: if you are already in one of these settings, do they make you move if you no longer meet the new guidelines? And so I think that kind of refers to the ambulatory or mobile non-ambulatory, or the level of assistance you need with your ADLs. And so primarily, yes, if somebody has been living in a personal care home like Morning Point, and they have a stroke and are no longer able to get themselves out of bed or move themselves in their wheelchair, then it is likely that they no longer meet that level of care requirements. There are ways to basically waive the ambulatory requirement if it is expected that in 6 months that person will be able to walk again or move themselves in a wheelchair. So if you have a stroke in personal care and you can't move yourself in a wheelchair, but you go to a nursing home for rehab and then plan to return back to that personal care home able to move yourself in your wheelchair, then you shouldn't be discharged. But if somebody's dementia has progressed to the point that they are no longer appropriate for personal care, OIG will cite the personal care home if you continue to allow that person to live there. There are some families that try to do some one-on-one sitters, or they bring in home health, things like that. So that could be an option for some people, but that becomes a really expensive setup very quickly. Okay, so I think unless anybody else has any questions, that covers the changes in assisted living and personal care. So one other change that is really important to the Ombudsman program is that the Centers for Medicare and Medicaid Services, which they are the regulatory body that basically creates the regulations for any nursing home that accepts Medicare or Medicaid. And there are very few nursing homes that don't take Medicare and Medicaid. In the Lexington, Central Kentucky region, Taylor Manor is a nursing home in Versailles run by the Catholic Church, and they do not take Medicaid. But most nursing homes take Medicare or Medicaid or Medicaid. And so the Biden administration issued some nursing home reform that required the centers, I'm going to say CMS, the Centers for Medicare and Medicaid Services, to issue a staffing standard. Current regulations from CMS and from Kentucky basically just state that nursing homes have to staff to sufficient levels, quote, sufficient levels to meet resident needs, which is really difficult to to quantify and therefore cite. The only time that I've ever seen a nursing home get cited for short staffing has been if OIG goes in and there's a resident that maybe needs 4 people to help them out of bed, and the staff only has 3 people that would be able to do that. And primarily that happens overnight. And so primarily OIG is not really able to see it or doesn't see it. They are able to go in at all hours, but for the most part they don't. And not anyway. So the CMS released their proposed rule on, I think, September 3rd, after months and months of it being late and late and late. And advocates are really disappointed. I'll tell you, long-term care industry is really disappointed. We're all fighting about it. But just to go over what is the rule? What is the proposed rule? And so the proposed rule has 3 big pieces that the Ombudsman program is focused on. Number 1, we are really excited about, saying that nursing homes are required to have an RN on site 24/7. Currently, you may remember when I was going over my charts, it's only 8 hours of an RN per day. And that's not really enough for nursing homes where people have been sicker and sicker. It means that people who have a fall in the middle of the night don't have somebody there to make an assessment of whether they need to go to the ER or not. So some residents get sent to the ER unnecessarily, and some residents sit in their bed in excruciating pain because nobody has been able to make the decision, does this person need to go to the hospital? So we are very excited about that requirement. We are very disappointed in the hours of direct care per resident per day. Most people think of staffing standards as a ratio, 1 CNA for every 8 residents. However, that in terms of like the science doesn't really match what people need. And so in 2001, a research study was done out of San Francisco, and it found, this researcher, Dr. Charlene Harrington, timed thousands and thousands of residents receiving the direct basic care services that they needed, like showers, like medication passing, like teeth brushing, like hair brushing, all of those little things that residents need throughout the day. And she found that to avoid negative health outcomes, residents need at least 4.1 hours of direct care of somebody in their room next to their bed providing direct care per day. And I will stress again, that is simply to avoid negative health outcomes. That's not to thrive, that is to survive. And so that was in 2001. And so in the last 20 years, nursing home residents have only gotten sicker, have only gotten older, have only gotten frailer. And so the advocate position is that 4.1 isn't even enough. However, the CMS rule only adds up to 3 hours of direct care per resident per day. And you'll see here, the study broke down, how much of that care needed to be provided by CNAs, LPNs, licensed nurses, and how many of those hours needed to be provided by registered nurses. And so when we compare what CMS has proposed and what the 2001 data shows, we are short in every category. RNs, we need, another 10, 15 minutes of RNs per resident per day. LPNs were not even included in the proposed rule. And so CMS has argued, well, we're just not saying there's a minimum of LPNs. Most facilities use LPNs, but we're just not saying that there's a minimum here. CNAs, we need another 20, 30 minutes for this level of care. And so we're extremely disappointed in that. And I'll tell you about what you can do about that in the next slide. But one of the other exciting things is that there's a requirement for some increased transparency. I don't know if you all are really familiar with a lot of the industry speak, but most people in the industry have been saying Medicaid doesn't reimburse enough. Medicaid doesn't reimburse enough. We're losing money running these nursing homes. Well, here's the freaking thing. If you're a for-profit company and you have shareholders, you're making a profit. I can basically guarantee it. And the way that they're making a profit is through piecing out the nursing home services to all these related parties. And I really can't get into that at this moment because we only have 7 minutes, but just let me tell you, it is infuriating, and it is a way that these companies are taking our tax dollars and our elderly's life savings to pad their pockets, to buy their 4th yachts, to go on extreme vacations, to have whatever the heck they want in their lives, while our residents can't even get somebody to come get them off the toilet after 45 minutes. It is disgusting. So this proposed rule also has a requirement that facilities must report the percentage of their Medicaid reimbursement that goes to direct care workers. And I'll tell you what, I don't know if it'll change anything, but it will be very telling to be able to see where that money goes. Okay, so what can you do about this proposed staff rule? So CMS, anytime any department or anything has a proposed rule, you can comment on that rule. There's a public comment period. And so that 60-day public comment period started on September 6th. So it ends November 6th. The Consumer Voice, which I will show a little bit more about in just a couple more slides, has a really great website, a really great page for you to read more about what the rule says, more about what our concerns are, and some suggested language. Here's the link to go. You have to give your name, but nobody says you have to give your real name. If you work in long-term care, or if you're worried about something coming back to you, we always, there's somebody that we know that always uses the name Reba McIntyre. You can make those comments, and the important thing is, the essential thing is that if you have personal experience with short staffing and what that meant for your loved one, or for you as you were in rehab after surgery, after knee replacement, please, I beg you to make those comments on this website, because they have to be looked at. And I'll tell you, the nursing home industry is filing comments, and they're filing comments about how there's a workforce shortage, but CMS worked with the Bureau of Labor Statistics to see that there is the workforce. The workforce is there, but it's not a workforce crisis. It is a job quality crisis. And these nursing homes need to start investing in their staff the way they're investing in their real estate holdings and other things. So if you'd like more information about that, you can tell that I'd love to talk more about it. You can call me. But just to really wrap up, just some things to get quality care: sign up for our email list here, ombuddy.org. Sign up for the Consumer Voices email list here, theconsumervoice.org. They've got all kinds of really great newsletters. We just do like a monthly newsletter. They do all kinds of options. You can do weekly, monthly, whatever you like. Get to know the local ombudsman, visit the facility regularly at different times, learn and exercise resident rights, learn about the other agencies that have oversight in the nursing home. To find every county in Kentucky has an ombudsman. So to find that ombudsman, if you're not in this central Kentucky area, or if your loved one lives somewhere else, click find an ombudsman. If you know somebody out of state, there's an ombudsman program in every state. So go to the Consumer Voices website, click get help, click the state, and you can find who covers that area. And if you have any questions, we only have 3 minutes, but I'd be happy to help here or offline. You can email me. If you have a specific complaint about a long-term care setting, you can also contact the Bluegrass District Ombudsman. She coordinates all the program, or all the ombudsman services in the 17 county central Kentucky area with these contact, or just check out our website to download that green book or books about residents' rights, whatever you need. And I will stop talking to see if there are any other questions.
I'll just reiterate what Amy said. Yes, thank you. This has been so helpful. I have learned a whole ton of stuff. Yeah, these new changes, it will take a while, so I think, for everybody to get used to a little bit. So your phone might be ringing off the hook, Denise.
I'll tell you, it is. Just since I've been on this call, my cell phone has rung twice. So it is a big change. But I think in the end, it's a good change. It's just a few things that I'm really disappointed in. But the industry really pushed Senate Bill 11 through, and then found that they weren't very happy with it as they wrote it. So it was a really hastily passed regulation or statute. Sorry.
Well, thank you very much for joining us today. I think we've all learned a lot. I will be sending out a recap and the YouTube video to everybody who registered for this event. So hopefully to see you next month, guys. Thank you.
Thank you all.